And good evening, everyone, and thank you for joining us for tonight's special event. We are blessed with Dr. Justin Schweitzer tonight to educate us on innovation in MIGS. I'm your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Abby for exhibiting at this event. We'll get to hear from them at the end of the presentation. So this will be worth 1 hour of CE credit. Please be sure to attend for a minimum of 50 minutes. For your COPE certificate, if you could fill out the survey link that's in the chat now, it'll also be there when the webinar ends. Your CE certificates will be delivered via email and sent to ARBO with your OE tracker numbers. You should receive an email within about 4 weeks with those CE certificates. We'll also have a QR code at the end of the event where you can use your OE tracker app to get the instant credit. Questions will be saved for the end of the presentation, so you can ask them either in the Q&A box or the chat at the bottom. And then if you're on your phone, you can find the Q&A either at the top or the chat under those 3 dots under more. So it's my pleasure to introduce our speaker for tonight, though he probably doesn't need much of an introduction. He's a frequent flyer at WU. So Dr. Schweitzer specializes in advanced glaucoma, refractive surgical clinical care, and anterior segment pathology at Vance Thompson Vision. They received his professional training in Doctor of Optometry degree from Pacific University College of Optometry in Forest Grove. He publishes, I'm sure if you've picked up a magazine or a journal article, you've seen him writing about one of his many specialties, and he's currently the chief medical editor of Modern Optometry. So he's also the board member of the South Dakota Optometric Society, board member of the Optometric Glaucoma Society, the American Optometric Society, Optometric Cornea Cataract and Refractive Society, Scleral Lens Education Society, Intrepid Eye Society, and is actively involved in communities eye care initiatives. So we're really excited to hear from you tonight, and looking forward to getting an update on MIGS.
Yeah, thank you so much. Excited to be here again. I always enjoy this, Ariel. Thanks for the warm introduction. I don't know. I keep trying to add up. This is, I think, my 4th time on WU. Might be one more, but it's always enjoyable. And just really excited for everyone to take the time away from family, friends, significant others to spend it with me tonight to talk about minimally invasive glaucoma surgery, which is definitely a passion of mine, and we'll get into that here shortly. Here's my financial disclosures. These all have been mitigated. And I do work at Vance Thompson Vision in Sioux Falls, South Dakota, and I work alongside a glaucoma specialist. He's cornea trained, cataract trained. My role in that practice is really to kind of manage the clinic along with my partner, Mitch Ibach. Him and I work together on a daily basis, and we manage patients that are really coming in from friends, colleagues, other optometrists in the community that are looking for surgical options for patients with glaucoma. Maybe it's a cataract surgery patient, refractive surgery patient. And so a lot of the glaucoma that I'm managing is sometimes mild glaucoma, but needs surgical intervention, or more advanced glaucoma that just needs another opinion, another discussion. And so love what I get to do on a daily basis. And I'm hopeful that tonight, what I'm going to share with you is some different cases, 3 different cases around MIGS. We're going to review all the different minimally invasive procedures out there and hopefully really empower you to say, boy, we do play a role as optometrists in managing patients with minimally invasive glaucoma surgeries, even if we're not the ones implanting the stents or performing the goniotomy. You're going to see here in a little bit with some of the data and some of the stats that we really have to be at the forefront of managing these patients and being available to these patients to help them through not only the preoperative discussion around MIGS, but also what's occurring postoperatively and then years down the road, because we know that a patient that has glaucoma is a journey, and none of these patients are going to be cured from any of these devices that we're going to talk about tonight. But boy, these devices can serve a purpose, and they can definitely serve a level of care that's going to bridge other treatment options down the road. And so I hope that when we're done today, that you'll feel empowered to learn a bit more about MIGS. Maybe this will be a review for you because you're already managing a lot of MIGS, or get you in the mood to talk to your surgeons to understand how you can partner with them more often to be involved in the care of your patients when it comes to minimally invasive glaucoma procedures. So all of us have had this type of patient before that's been in our office, the long-time glaucoma patient that is technically controlled. You look at this gentleman, he's someone that doesn't have an advancing visual field. He doesn't have an advancing OCT. I got his pressures very well controlled, but look at his complaints. My eyes are red on a daily basis. His vision fluctuates. He misses his drops. We have a lot of options that we need to consider for this patient. MIGS fits in there. We'll talk about some other options as well, but this is not a controlled glaucoma patient. And you'll hear me say this many times tonight that minimally invasive glaucoma procedures, they're surgery. And surgery always carries a little bit more risk than drops or doing selective laser trabeculoplasty or even drug delivery. But we need to move minimally invasive glaucoma procedures closer to the front of our treatment options for patients, especially like this that are on multiple medications or that have cataracts that we'll talk about a little bit here. MIGS are safe to a degree. Yes, it's inside the eye surgery, but as we talk through this, you're going to see that the safety profile of minimally invasive procedures is very similar to cataract surgery. And the data supports this as well when we look at FDA clinical trials around stents, when we look at data that's been published around goniotomies, those types of things. Yes, there's some nuances we'll need to understand, but from a safety standpoint, these should be towards the front end of our treatment algorithm, along with medications, SLT, and drug delivery. I want us all to kind of have this mindset when we get into talking about managing glaucoma. And I really think moving forward in the year 2025 and beyond, we need to have an interventional glaucoma mindset. What does that mean? What it really means is intervening earlier in the disease process with procedures that are safe, that are effective, that don't put our patients at risk for, progression or loss of vision. We don't want to wait till our patients have advanced glaucoma to intervene with certain things. So what treatment options in glaucoma kind of fall within this interventional glaucoma mindset? I would argue SLT does. Selective laser trabeculoplasty, we can utilize this to intervene early in the disease process. We can minimize the drop burden with it. You've heard me talk about glaucoma and dry eye many times. I've talked about it on Woo U, actually. I'm passionate about that. I love drops. I use them every single day, but how do we minimize the burden of them? A patient that's on one medication is going to be much more compliant than a patient that's on two or even on three, and we'll look at some data around that as well. Drug delivery. Drug delivery, although not technically a MIGS procedure, is that interventional glaucoma mindset. We're able to deliver medication inside of the eye, removing bottles or a bottle from the patient's hands. And we really have two different devices out there now. We have one called Optometrist SR. We have another one that delivers travoprost with a stent that's placed inside the eye. And then finally, we have our MIGS procedures, which we're going to focus on tonight. They definitely fit into the interventional glaucoma mindset because we can intervene with surgical procedures earlier in the disease process, earlier than ever before, and manage, and they're efficacious for our glaucoma patients. Tubes and trabs don't fit into that interventional glaucoma mindset. They're not going away. We're still going to need them. There's still things that we're going to need for our advanced glaucoma patients, but they come with a ton of risk, opposite of what we see with MIGS. So when we talk about MIGS, this is the definition. They're procedures that have an ab internal approach, are minimally traumatic. They're at least modestly effective, not as effective as tubes, not as effective as trabs, but they still get IOP lowering, and I'll show you that tonight, hopefully with some of the data. They have a high safety profile, and these patients recover very rapidly. And I like to think of them as bridging a gap. We have our conservative therapies, which I would argue is medications, topical medications, SLT, drug delivery, that's on the conservative side. Aggressive tubes, trabs. And right in the middle there, we have that MIGS option to bridge that gap between conservative and aggressive therapies. The other piece to this is the collaborative care piece. Very, very important that we communicate and interact with our surgeon colleagues that are performing these different procedures. Talk to your surgeons that you're referring to. I want surgeons that are performing multiple MIGS procedures because not just one MIGS procedure is going to be ideal for every single patient. If they're just doing stents, I want them doing more than that. We want goniotomies. We want canaloplasties. There's a variety of different MIGS procedures, as you'll see tonight. Some fit better for pseudofakes. Some fit better when they're in combination with cataract surgery. And the most important thing is to work with surgeons that are willing to work with you. So preoperatively, preparing patients, but post-operatively, they're back in your chair, but also surgeons that are using multiple MIGS procedures. And so this collaborative care piece is so crucial, because if we don't embrace this, the only people that are hurt are our patients. Doesn't really hurt us, doesn't really hurt the surgeons. It's really hurting our patients. And so collaborative care really crucial as we kind of go on this journey together tonight when we talk about minimally invasive procedures. I alluded to this a little bit, why MIGS? Why as optometrists should we really care about minimally invasive procedures? We're not the ones that are inserting these. We're not implanting them. We're not getting paid to put them inside the eye. So why should we care about them? Number one, we're going to have to care about them because the sheer number of patients with glaucoma in the United States is going to only continue to increase. By the year 2040, 4.1 million. By the year 2050, 6.3 million Americans are going to have glaucoma. And the other fact is ophthalmology is not going to be able to keep up with managing all these patients. So that leaves optometry to embrace the management of these patients. So we're going to be forced to. So that's a real good reason why we should care about minimally invasive glaucoma procedures. Two would be compliance. It will make our lives easier managing our patients if we can reduce the medication burden. Again, I love medications. I utilize them on a daily basis, but less is better. You're looking at two different studies here, the Nordstrom study on the left, a Travatan dosing study on the right. The Nordstrom study, you can see the data there. 50% of patients discontinued their medication before 6 months. All different classes, prostaglandins, alpha agonists, CAIs, beta blockers. And then the topical glaucoma adherence study where they were given medication for free. These patients were told, hey, we're going to monitor you, so you better take them. And still, over half the patients used the drop less than 75% of the time. Even though they knew it was free, even though they knew they were being monitored, they still couldn't do it correctly. So how do we minimize that burden on our patients? And then finally, patients are going to get worse on us if they can't tolerate their medications. And so you have a study here looking at patients with no side effects in the blue, with side effects in the red. If we can minimize side effects from topical medications, and how do we do that? Well, MIGS can play a big role in that, because as we look at the data here in a little bit, almost every MIGS procedure will reduce some of the medication burden. These patients will likely progress less rapidly. And you look here, the side effects in the red, the no side effects in the blue, the gap forming over time, that's a gap of progression, with side effects progressing more rapidly than with no side effects. So here's kind of the introduction to the different types of devices we're going to talk about tonight. I kind of put a little table together here. We have stents, we have Schlemm's canal dilation, and then we have trabecular meshwork cutting devices. And some of these are combined as well. And on the left, there are some of the post-operative considerations and some of the data around these. So when we think about stents, really not any fibrosis risk with them. Hyphema is very minimal with these, and we'll touch on this here in a little bit. PAS, very minimal or low risk, and we'll look at the data on that as well. IOP lowering, pretty good. And then the data, this is where we have the most robust data. So stents have been heavily studied. We have long-term data on these. We have 5-year studies. We have 7-year studies. We have 9-year studies on stents. So we have long-term data, a lot of data showing that they're effective and they work. They don't cure, but they're effective at lowering IOP. Then we have our Schlemm's canal dilating devices, plus minus on the fibrosis risk, plus minus on the hyphema. You kind of get the picture here. There's less data around Schlemm's canal dilating devices, but we still utilize them a lot of times in our pseudophakic patients. And then our cutting devices, a little bit higher risk of fibrosis, more risk of bleeding, more risk of scarring down in the angle, but the data supports they have very effective IOP lowering techniques when they work. And we also have better data around these as well, more and more of that coming out daily. So kind of keep this in mind when we get into talking about the different procedures that we're going to get into. So here's a quick case. This was a 71-year-old patient with irritated, blurry eyes. You can see his best corrected visual acuity about 20/30 and Tmax pressure before treatment 29/28. Currently taking 2 bottles of medication, really 3 medications, latanoprost and a fixed combination agent twice a day. Intraocular pressure being 20 and 19. And you look at the Tmax pressure, 20 and 19 now, I would say, boy, that's a pretty good reduction. We need to see the OCT. We need to see the visual field. But I feel pretty good about where his intraocular pressure is for seeing him for the first time. Cup to disc ratio, some asymmetry there. He's got thin corneas. He's got a low corneal hysteresis, so a lot of risk there. Gonioscopy is open to the ciliary body. And then slit lamp exam, you can see that he does have a visually significant cataract. And we'll get into a little more here of a few other images, the visual field, the OCT, so on and so forth. Here's how his anterior segment looks. Pretty beat up. I'm sure many of you have glaucoma patients every day that walk in looking like this. And we say, boy, we got to make sure they don't go blind, but we still got to care about this as well. We see he's got a visually significant cataract. He's got a beat up ocular surface. We need to get the surface under control before we do cataract surgery, or we figure out a way to reduce that medication burden for this particular patient. Here's his OCTs. We can see that he has temporal superior, temporal inferior retinal nerve fiber layer thinning in the right eye with an inferior ganglion cell defect. We also could see on the left eye that he's just barely got some thinning temporally. If you look at the kind of retinal nerve fiber layer thickness, if you could see my pointer here, he's right at the edge there, right on the borderline portion there. Here's his visual fields. Left eye visual field matching what we see with the OCT. Looks pretty clean to me. Looks pretty normal in the left eye. If we go back, left eye over here. Look at the right eye. This kind of paracentral defect is concerning to me, mainly because with this temporal RNFL thinning, with this inferior ganglion cell defect and this paracentral defect, to me, I'd obviously repeat it, but you got to make game time decisions at certain points. He's in your clinic for an evaluation. That to me is a very structure function matching type of visual field issue. And with all the risks that this patient has on multiple medications, I agree that this patient has definitely glaucoma in his right eye, preparametric glaucoma probably in his left eye, had pressures of 29, 28, thin corneas, low corneal hysteresis, on 2 medications, so fairly well controlled. What do we do for this patient? For me, this is the low-hanging fruit MIGS patient. This is a patient where we're going to make his life better because we're not only going to make him see better, we're going to remove the cataracts. We're going to also place a couple stents. You can see the video here of the surgery being performed. And my goal for this patient is, number one, I want an IOP similar to pre-surgery because I don't really need a pressure of 12 or 13 at this point in time. I would love to have a pressure at 20 to 19 and see if he's stable at that pressure. His Tmax was 29, 28. We got him at 20 19, but I want to get him off some medications. I would love to get him off of 1 medication. I would prefer to get him off of 2 medications. And then I want to manage that ocular surface. So you can see the results for this patient. He was 20/20 after surgery, IOP at 6 months, 17 and 18, still on a medication. Ultimately needed that because we weren't reaching target just with stents alone. But we put him on a preservative-free latanoprost once a day to make sure that he didn't get back to where he was pre-surgery. And so currently this patient doing very well, good intraocular pressure, much happier ocular surface, much better visual acuity. So what do we think about postoperative as optometrists if we're going to manage a patient like that? These are kind of the 5 things that I think about. 1, when do I stop my glaucoma medications? 2, how do I deal with IOP spikes? 3, hyphema. Stents can cause hyphema, so can goniotomies. So how do we manage those? Is hypotony a concern? And establish new baselines. So let's talk about stopping glaucoma medications first. Really, with stopping glaucoma medications, it goes to the severity of the condition, in my opinion. And MIGS still is in its infancy. We don't have a good cookbook recipe for this. It really just takes experience in managing a lot of these patients to say, boy, I'm going to stop it now, or I'm going to wait a bit longer, but I'm going to try to give you some guidance around this. If the patient is more ocular hypertensive, preparametric, mild glaucoma, I'm much more aggressive at removing medications. Our previous patient, baseline pressure was 29, 28. We knew on medications, really 3 medications. He was 20 and 19. No evidence he's progressing necessarily. I'm going to be pretty aggressive in getting him off his medications. And I typically wait till about the month mark. And why I wait that long is just to prevent any type of IOP spike that could occur from being on topical corticosteroids. Some of the surgeons will put it inside the eye. So I typically tell my patients, hey, we're going to leave you on your medications for about a month, and then we're going to start peeling them off, and I'll peel 1 off at a time. With this patient, being that he had some ocular surface disease problems, being that it was fairly mild to a degree in the one eye, I feel more confident removing a medication a little bit earlier in his particular situation and leaving 1 on board. And so I would fault no one if you said, boy, his pressure's at 20 and 19 at 1 week. I'm going to go ahead and peel the medication off. But rule of thumb for me is typically medications stay the same until about 1 month, and then I start peeling them off one at a time. In regards to a more advanced glaucoma patient that's undergoing a MIGS procedure, the preoperative discussion is so important. In those patients, I'm going to remind them that the MIGS procedure we're doing is likely just like adding a medication. A more advanced glaucoma patient, like the one you see on the right there, probably isn't necessarily going to get off medications. The MIGS procedure is really designed to be an additional IOP lowering device in combination with their medications. Now, if we happen to reach target pressure, because we all need to be setting target pressures of what our goal is after a MIGS procedure, then I'm willing to try to peel a medication, but I'm much more cautious in those scenarios. So the level of the glaucoma matters, the level of how many meds they're on matters, and then just thinking about when do you peel those off. This is the other thing I want to encourage you to do with your MIGS patients, especially your stent patients. You should be doing it with your goniotomy patients as well. Be very good with your gonioscopy skills. You want to take a look at the stents or the gonioscopy or the goniotomy within the first 3 months at least one time. You can bill for that. It's a medical reason you're doing it. And then once a year, you should be putting the goniometer on and taking a look to make sure that these stents are functioning, that there's not a little tuft of virus that's sticking in the end of them. You can see that the percentage of PAS is very low in the clinical trials around stents, but they do exist. And so it's a very easy, quick fix. Our surgeons will take a little YAG laser and they'll kind of zap or get rid of the little tuft that may be plugging the stent. But get good with your gonio skills because you want to be able to look at these stents. You want to be looking at goniotomies to make sure that they're still functional and not fibrosed. Hyphema, a very common thing that can happen. And when we think about hyphemas, it really can happen with any MIGS procedure. Remember that table earlier that we talked about? And stents, least likely to cause hyphema. Schlemm's canal dilating, and then obviously trabecular meshwork cutting, you're going to see more of this. But if you see hyphema like this, educate the patient and don't do anything. Just continue with your postoperative management. It's better that they hear about the hyphema on the front end. So I tell every single patient that's undergoing a MIGS procedure that, hey, you might get some blood inside the eye. If that happens, you're going to be cloudy for about a week. That's going to go away. There's nothing that we're going to really do or change. And I'll remind you on your 1 day post-op or your 1 week post-op. So a layered hyphema like this, very common, nothing you need to necessarily do. I don't restrict activities. I don't have them, lie down any differently when they go to bed at night. I just educate them. It might look like an anterior chamber reaction like this kind of snowflake reaction. Looks like there's an anterior chamber reaction, but it's really blood floating around the eye. And then the one time I would send back to the surgeon would be if you ever get a hyphema that fills up the anterior chamber like this particular patient did. This was a MIGS patient of mine. It did fill the anterior chamber. This was a patient that we had to get back to the surgeon to be able to remove that blood. There's just high risk of IOP spikes, corneal staining. And so I would send a patient like this back. But the majority of the time, you're going to see the first 2 images and not that third image. IOP spikes. I'm going to encourage you and empower you that with a glaucoma patient, you need to get the pressure down fairly quickly. They're at more risk because the nerve's at risk. And how do we do that? Well, anterior chamber decompression is a really nice way on day 1 to get their intraocular pressure down. And in this video, you can see that I'm burping a wound, anterior decompression. Give the patient a couple of drops of proparacaine. They'll like you a lot more. And then you want to burp the small wound. There's typically 2 wounds, a large wound and a small wound. You'll take that punctal dilator. You'll press just outside the wound and burp a little fluid out. You may need to do it once or twice to kind of get that fluid to come out. This video is on a repeat, so I promise you, you don't want to burp the wound this much. You'll take the pressure down to 0. I did that on purpose so I could talk over it. But really, it takes 1 or 2 just burps or pressure on the outside of the wound. You don't have to go inside the wound to get that fluid to come out or that viscoelastic to come out. And then with these patients, because typically glaucoma patients have the risk of it spiking back up, I'll keep them on their medications. And I usually see them back 24 to 48 hours to make sure that they're doing okay. Remember, they're already on an antibiotic. They already have an antibiotic probably inside their eye. So as long as you don't stick that dilator inside the eye, you're perfectly fine in doing so. Some docs like to use a Q-tip. Some docs like to use, the blunt end of a needle. Whatever you're most comfortable with is fine. I love a sterile punctal dilator. I think it's easy to utilize, and I'm able to burp the wound fairly easily with it. Hypotony with MIGS. Really, the only one you have to be concerned with this is a subconjunctival stent. We'll touch on that here in a little bit. Really, the other MIGS procedures we're going to talk about tonight, you don't have to worry about hypotony because there's no bypass of episclerovenous pressure. Remember, episclerovenous pressure, that kind of 9 to 12 millimeters of mercury backstop pressure, it's going to prevent stents, goniotomies, ab-internal canaloplasties from creating hypotony. And so we'll talk a little bit about hypotony here in a little bit when we get into talking about Zen stents and make sure that we kind of understand those as well. So real quickly, I'm going to go ahead and just touch on a few of the different devices. I'll go through these fairly quickly. Trabecular microbypass stents. This is the newest generation where the cataract comes out and then the surgeon places 2 stents. You saw this video earlier with our patient that we utilized. Keep in mind that currently on label, this has to be done in combination with cataract surgery. If we look at the data around this particular device, that's good. This was their pivotal trial. The primary endpoint looking at a greater than 20% reduction in unmedicated diurnal intraocular pressure. You can see over 3/4 of the patients achieve that in this study. They compare this against cataract surgery alone. And then on the right, the secondary endpoint, they saw about a 7 millimeter of mercury mean unmedicated diurnal intraocular pressure reduction as well, outperforming cataract surgery alone. And the bigger take home here is reduction in medication, lower IOP, outperforming cataract surgery, and didn't create more risk for the patient. So again, low hanging fruit, your patient that has a visually significant cataract, mild to moderate glaucoma, should be getting a MIGS procedure because you're not adding any risk to the cataract procedure in doing so. This was a study that we performed. This was just a single trabecular microbypass stent. This was a while ago, 2016 that we published it, but I think still very useful. Why? Just keep in mind that stenting typically works better in a higher baseline pressure situation. That's really what we showed here. Our patients that had pressures of 24 or above got nearly, or they did get over 12 millimeters of mercury IOP lowering with one single stent plus cataract surgery. Now, if those patients' baseline pressures were lower, they got less IOP lowering. That doesn't mean we shouldn't consider it in those situations. This is just helpful to educate patients. You have a patient that comes in, they're on one medication, they have a pressure of 28, they're on that latanoprost, they have a visually significant cataract. You can feel pretty confident that when you recommend cataract surgery plus a stent, based on data that's out there, that you're going to get a pretty robust IOP lowering for that patient. The difference would be if they have a pressure of 17 to 19, you may not get as much lowering. You still may consider it, but you may need to do something more aggressive based on the clinical picture. Here's a Schlemm's canal micro stent. So this is a device that penetrates through the trabecular meshwork. It dilates the canal as well. Scaffolding device takes up about 3 clock hours of the trabecular meshwork. Aqueous is able to flow through the stent and access Schlemm's canal and then go to those aqueous collector channels. This also has to be done in combination with cataract surgery. That's its on-label usage with it. The Horizon trial, if you're looking for some light reading tonight, is the study you'd want to look at. This is kind of the 5-year data around it. They also have some 6-year data as well. Take homes, just kind of summarizing this. Number one, again, stent plus cataract outperforms cataract surgery alone. You can see at 60 months, 66% of patients were medication free. That's the second kind of line right here versus less than 50% in the cataract only group. I think the other take home here is that it wasn't just patients that were on one medication in the stent plus cataract group. You can see that 50% of them were on 2 to 4 medications. What that tells me is that a lot of these patients weren't just pre-parametric glaucoma patients. These were more advanced glaucoma patients as well, a nice spread of glaucoma patients. Another really interesting data point that came out of the Horizon trial is they looked at visual field data. And a lot of times with these FDA clinical trials, we're just looking at IOP lowering. We assume if we're lowering IOP, we're stopping progression. What they published in American Journal of Ophthalmology in 2023 is this stat, looking at the visual field data from the Horizon trial, which we just saw on the last slide, that the micro stent lowered the rate of visual field progression per year 47% more than what cataract surgery did alone. And so again, pairing a stent plus cataract surgery, outperforming cataract surgery alone, not only in lowering IOP, not only in reducing the medication burden, but on top of it, slowing or reducing visual field loss per year as well. Finally, quality of life, helping our patients' quality of life. These stents do that as well. This was a study that I did along with a couple of my colleagues, ocular surface disease improvement in patients with implanted eyes. We did one stent in these patients. Some of them got two. It's a small study, a pilot study, 47 patients. We had them take an OSDI beforehand. Preoperatively, their OSDI was 40.1. That's advanced on the OSDI. They underwent cataract surgery plus a stent or stents. You can see at month 3, their OSDI dropped to 17.5. We would expect that, I hope. Not mind-blowing data, right? We get them off of medications. These patients were on 1.5 medications before surgery. At the end of surgery, they were on a half a medication. We reduce that medication burden. We make their symptomology better. But on top of that, you can see we had a 49% increase in their tear breakup time. We saw less corneal and conjunctival staining, and we also saw less hyperemia as well. So another reason that we want to consider MIGS, this goes exactly to our patient that we just talked about. Bad ocular surface disease, glaucoma is likely controlled, complaining of his vision. How can we help all three things? His vision, his glaucoma, and his ocular surface. MIGS fit into that kind of category. And they work. This is data or a study and a video of aqueous angiography showing how well stents actually work. This is fascinating. This video is to me. You look on the left side, this was before stents were placed, and I'll repeat this video for all of you. Inferior in that image, you can see there's some flow of aqueous right down here, but it's all dormant up here. Superior, kind of on this temporal side over here, really no flow of aqueous happening. Let's play that video once more. Watch the right side now after stents are placed. And there's 2 red arrows where those stents are placed. And now you can see a lot of aqueous flow occurring, not only in the dormant areas, but in areas where there was already aqueous flow. And so this is really interesting data, really interesting videos. I mean, the holy grail of MIGS will be someday, can we do this efficiently in the operating room so that surgeons are then able to target areas where there's dormant areas that there isn't flow, or target areas where there is flow and they want to get more flow to that area. All right, case number 2. So this was a patient that had previous cataract surgery. Intraocular pressure was 17 in the right eye, 18 in the left eye. Tmax, again, very important to know, 26 in the right, 25 in the left. Again, patient on 3 medications, a prostaglandin and a fixed combo agent, so 2 bottles. And you can see from the images, again, ocular surface disease. And this was a patient that had rheumatoid arthritis and had a lot of complaints about utilizing her drops, unable to kind of squeeze the bottle, unable to be able to take it consistently. Pachymetry, pretty normal. You can see the CD ratio here, 0.75 vertical, 0.8 vertical, right and left. And then gonioscopy was open to the ciliary body with some mild pigment. Moving things along, we look at the progression here over time. So you can see that this patient, if you look at the OCTs here, July of 2021, July of 2022 to July of 2023, and then this large ganglion cell defect we're noticing here as well. There is progression occurring from a structural standpoint. We're seeing temporal superior thinning. We're actually seeing the temporal inferior quadrant thin in front of us as well, from 2021 to 2022 to 2023, and then the overall average dropping as well. So we have the structural damage in this patient. Again, with pretty good intraocular pressure, we would think at 17 and 18. And then we also see subtle progression on the visual field. So now we have functional, and it's very subtle. You can see the pattern standard deviation just getting a little bit worse year after year after year. Now, it's not aggressive progression, and it probably would be aggressive progression if we didn't have this pressure at 17 and 18 down from 26 to 25. Is it staying at 17 and 18? Hard to say. Could be fluctuating. Point is, something needs to be done. What do we do with a patient like this where they're on multiple medications? We could consider an SLT. The problem is adding an SLT to multiple medications like this can work, but what should we expect? We should only expect to get what we'd expect if we add a 3rd medication. So not a big reduction SLT isn't going to get us a 30% reduction, right? There's already 2, 3 medications going. It's going to get us about what we get with a third medication. We could consider drug delivery to take the place of that prostaglandin, but this is a prime patient that's progressing, not tolerant of their medications, not doing well, where I would strongly consider a referral for a MIGS procedure. What are our MIGS options here? Well, stents really aren't a great option, at least the ones we just talked about. We'll talk about a different set of stents here in a little bit. Reason being, they have to be done in combination with cataract surgery. This patient is a pseudophakic, has already had cataract surgery. And so this is where our goniotomies come into play, our viscocanaloplasties come into play. And so let's talk about those after I tell you what we did with this patient. In this particular situation, we did an ab interno trabeculotomy plus canaloplasty. And so this is a procedure that dilates Schlemm's canal, injects a little bit of viscoelastic as they're removing the catheter with the viscoelastic. They can also strip the tissue as well. And I'll touch more on this. I'll show you a video of this here in a minute. But you can see this particular patient at 3 months had pressures of 15 and 14 and wasn't taking any medications. And so this is a big win for a patient like this. Now, we're going to continue to monitor this patient because very likely they're going to change or things could change. But we now got their pressure down into the low teens. They're not having to take their medications anymore. And hopefully we'll be able to hold this at this level for years. Now, when we look at the patient's age, we didn't put that up here, but this was a patient that was in their early 70s. And so still, we got some time to buy. We need to prevent them from having more vision loss. And we look at the visual field here, there's a paracentral defect. So a little higher risk type of patient. And we're talking just in the right eye. I think everyone probably figured that out. You're only seeing one eye here. We're not looking at the left eye. The left eye actually was staying very stable. The other thing you can add quite often, and you see it in this case, is something called ECP or endocyclophotocoagulation. Love to add it to procedures like this because what are we trying to attack here? We're trying to attack the outflow. So the ab interno trabeculotomy plus canaloplasty is opening up the trabecular meshwork. It's opening up Schlemm's canal. It's accessing those collector channels that we saw in the video earlier. But we also can reduce aqueous production by doing ECP, cilioblading those ciliary processes where aqueous is being produced. So combining these two can be a very effective way to manage our patients. So here's the quick animation of how this procedure works. Catheter is through the trabecular meshwork, placed into Schlemm's canals. They retract it. They're injecting viscoelastic, breaking up any adhesions that are in there, dilating the canal as well. They'll typically do this 360 degrees. Don't have to, can only do it 180. And then they'll go back in with the catheter, and this is an added piece to it, doesn't always done, and they can strip the trabecular meshwork. They can remove the trabecular meshwork at this point in time. And postoperatively, you're managing hyphema quite often. We talked about how do we manage that. You're managing some IOP spikes as well. You can see in this particular animation, they're actually stripping trabecular meshwork 360 degrees. The surgeon I work with typically viscodilates 360, but only strips 180. So that's the ab interno trabeculotomy plus canaloplasty, typically done in pseudophakics, can be done in combination with cataract surgery. The reason why we don't typically do it in combination with cataract surgery is I really like to preserve the trabecular meshwork for as long as possible. I love to stent first, preserve that meshwork, save something like this for later down the road, because as soon as that trabecular meshwork is stripped, we don't have the ability anymore to place stents. And so I love stenting first, if at all possible, save goniotomies, this particular procedure for down the road. There is data on this, more studies coming out. As I mentioned earlier, the stents really hold the trophy for the most studies, the most long-term data. Trabeculoplasties, or this procedure, the trabeculotomy, goniotomies, there's more data that's coming out. This is the Romeo study showing 2 different groups, one with a high baseline, one with a low baseline. What you're seeing here is what we talked about earlier. Higher baseline pressure patients are going to get a bigger bang for their buck. Lower baseline pressure patients, not as much, but they still get some. And we see a reduction in medication in this study as well. Just a quick video showing you ECP. I kind of talked extensively on this already, but cilioablating those ciliary processes. This patient actually has pseudoexfoliative syndrome or pseudoexfoliative glaucoma. And you can see a lot of shrinking occurring to those ciliary processes as he's going ahead and applying that endocyclophotocoagulation. There's a variety of different goniotomies out there. Many of you are familiar with this. You have excisional goniotomies where they're going to go inside the eye. They're going to strip about 3 clock hours of the trabecular meshwork. That's the first video you see there. That's typically done in combination, in pseudophakics. It can be done in combination with cataract surgery as well. The next video, another goniotomy where they're actually punching 220 micron holes in the trabecular meshwork to allow aqueous to flow through there. And then the last image there, it's not a video, is just another device that is stripping or opening up Schlemm's canal, removing that trabecular meshwork. More and more data coming out on these procedures as well. We look at an excisional goniotomy study that we performed at our center. You could see baseline pressure in these patients was about 21. Followed them through a year. We saw about a 25% reduction in intraocular pressure. And when you look at IOP reduction, we saw about a 20% reduction in intraocular pressure as well. And these were all types of patients, mild all the way to severe. This is another procedure that some of you may have seen. I wanted to share a quick video, not maybe used as often. It's a procedure called Streamline. Really what they're doing with it is they're creating tiny goniotomies. So this device will create little holes in the trabecular meshwork as pressure is placed against there. And then as it's creating those little goniotomies or those holes, it's injecting viscoelastic in both directions and really opening up the trabecular meshwork. So another procedure that you may run into, again, a little hole placed and then viscoelastic being injected to kind of dilate the canal. The nice thing about this procedure is it's preserving the meshwork, still creating an opening, preserving more of the meshwork and dilating Schlemm's canal, breaking up adhesions as well. And then a more recent device. This is a trabecular micro bypass device, 3-stent device. This is really meant for more advanced glaucoma. We've always had stents for our mild to moderate glaucoma patients in combination with cataract surgery, but we really never had stents for more advanced glaucoma. And so this is FDA approved. This is being utilized. The surgeon will place 3 stents in this scenario, can be done in pseudophakics. That's when it's typically done. The indication is usually patients have failed with medication or failed with other surgery, and then we will utilize this. The meshwork has to be intact though. That's a very important piece here because the stent doesn't have a place if a goniotomy has been performed or a viscocanaloplasty where we saw that stripping procedure is performed. So a 3-stent device system and the data around it, very impressive. You look at this 12-month pivotal trial study. This is FDA approved now. It says not approved on the bottom of the slide there. This is FDA approved. You can see 3.1 hypotensive medications at baseline. 50% of these patients achieved 30% or greater IOP reduction. And there was a 13% mean reduction in medication burden from baseline, which is impressive when you think about how many medications these patients were on. So a safe procedure involving a stent option. Final case, we have about 11 minutes left and then we'll wrap up. So this was an 84-year-old Caucasian female, history of glaucoma for a long time. And I'd been following this patient for an extended period of time. They were diagnosed back in 2012 to 2014. And you can see in the right eye, a lot of medications. They're on, a prostaglandin, they're on a fixed combination agent, and then even a single agent. So really 4 medications, 3 bottles. They have a history of multiple procedures. We've done some stenting procedures. We've done a goniotomy with stent removal. So a lot of surgery on the right eye to kind of preserve it. The left eye had significant glaucoma when we inherited this patient. And so there's a tube shunt present. You'll see the visual field here in the left eye fairly soon. And then they'd already had cataract surgery as well. Medical history doesn't really come into play here. And then if you look at the ocular exam, vision's still 20/20 in that right eye. Left eye down to 20/40. You'll see why with the visual field here in a second. And we were able to obtain Tmax pressures, 24 in the right eye, 28 in the left eye. Tube shunt in the left eye, otherwise really unremarkable from a slit lamp exam standpoint. Advanced glaucoma, just based on the optic nerve head, you can see a 0.8 in the right eye, 0.95 in the left eye. Pachymetry thin, gonioscopy open. And the IOP history, very important. You look at the left eye, consistently at 10 to 11 with that tube shunt. Tube shunt eye, not good. Advanced glaucoma, you see this is the left eye 10-2, but stable. This is one from 2021, and the patient is still continuing to be stable. Really no changes, and their pressure, again, consistently 10 to 11. So I really haven't any concern with the left eye, except that the vision is declined at 20/40 and has kind of been that way for a while. The right eye, on every office visit, consistently had pressure of 10 to 12. This was on those medications. Felt pretty good about that as well. And the patient was, for a long time, very, very stable. But now look what started to happen in 2019 on me, in 2020, really in a 6-month period, pretty aggressive progression occurring. And it was repeatable progression. We see that in May of 2020, there's a nasal step with a superior arcuate defect. We see in October, it's progressing as well. We look at the OCT. We see progression on that as well from May to October. Fairly significant thinning occurring over that time period. And so the question goes back to, well, what's happening? Why is this patient getting worse on me? Because they are, and it's significant, especially when we look at this consistent IOP of 10 to 12. Could it be compliance? Yes, it definitely could be compliance. The patient may not be taking their medications appropriately. It could be IOP fluctuation. That's another consideration. And so a technology that I will utilize at times when the clinical picture isn't matching up specifically with the IOP is I like to do some at-home IOP monitoring. I'll send an at-home device with the patient to kind of get an idea of what's going on. And if you look at this patient's data for at-home monitoring, you can see that in the mornings, they typically had a really good intraocular pressure, 10 and 13, 13, 13, 15, 15, 14. Very similar to what I saw when they were in our clinic measuring intraocular pressure. But in the afternoon, this patient's pressure was spiking, 26. We have a 29 a couple times there. We have another 26. We have a 24. And so very likely over an extended period of time, we were controlling the glaucoma, but we weren't controlling it well enough. And the patient was spiking, and that's why we were seeing progression. That's why we were seeing changes occurring over time. And so the next question is, well, what do we do with this patient? We have to prevent these fluctuations. We know from the advanced glaucoma intervention study that progressive glaucoma and fluctuations go hand in hand. So what do? They've already had stents. They are on multiple medications. We could consider drug delivery, but that's not really probably going to solve our solution since they're on 4 medications. SLT isn't going to really solve our solution. They've already had goniotomies. We need to move into a little bit more of an aggressive arena with MIGS procedures or more MIGS plus procedures. And in this particular case, we went ahead and did a subconjunctival stent for this patient. So this is like a mini tube. We'll play the video of it here. And so we do have to worry about hypotony with this type of patient. So there's a little incision made. You'll see a little needle coming across the anterior chamber. The stent is inside that needle. They're going to penetrate at the level of the trabecular meshwork. And if you watch very closely where that needle's going in, you're going to see the most delicate part right there. He's got to make sure he does not puncture the conjunctiva. The stent is placed. And now you have aqueous that can flow from inside the eye to this subconjunctival bleb. And so you do have to be comfortable with managing blebs for this particular patient. They'll inject a little bit of mitomycin C. Some surgeons like to do this ab external. Well, they'll take the conj down and come from the outside in. Our surgeon prefers to do it ab internal. You can see this patient at 3 months did extremely well. Pressure's at 10, no medications at this point in time, and a stable visual field. I can tell you that now because it's the year 2024 and I'm still managing the patient. So stopping those IOP fluctuations with this particular device has really prevented more progression. From a postoperative standpoint, if you manage these patients, what are our considerations? We have to worry about hypotony. Very commonly on day 1, these patients' pressures are going to be 2 or 3. And so you want to stop all their glaucoma medications. Take a look at the eye. Make sure that the anterior chamber is formed. A shallow anterior chamber is okay. A flat anterior chamber is not okay. That goes back to the surgeon. And so if you see the cornea touching the iris, I'm definitely sending that back. And then I like to take a look in the back of the eye especially if we have a pressure of 2 or 3, just really quickly to see if there's any choroidal folds, just get an idea if that's occurring. They're not always there. And then you're going to monitor this patient at 1 week, 1 month. They're going to be on topical steroid for about 3 months. I'm going to keep them off meds if at all possible. The most common issue that we run into with subconjunctival stents is that little bleb kind of fibroses down. And in their FDA clinical trial, you could see it on the bottom right there. Bleb needling about 32% of the time needed to occur. 2 tricks to managing these patients if fibrosis occurs is, 1, they may need a bleb needling. But if I see a high pressure early on in the postoperative period, a lot of times what we'll do is our surgeon will use a YAG laser and they'll YAG the tip of the stent right here. And the current that the YAG creates, if there's anything plugging the stent, a lot of times it's inflammatory debris, inflammation from the surgery. You can push that inflammatory debris forward by just yagging the end of the stent. And so that's one step early on in the disease process, or a bleb needling to get that functioning as well. This is again for more advanced glaucoma. These are for our patients that have, refractory, they failed with other things. It's not going to be for your patient with mild to moderate glaucoma. This is just the ab external approach. So they puncture at the level of the trabecular, or excuse me, at the conjunctiva. Some will take that conj down. They'll go ahead and puncture through here. You'll see the needle kind of come out on the other side. Not quite all the way through. And then you'll see the bleb form here really quickly once she injects this. And there's the bleb. And so it's surgeon preference in how they do this. More importantly for us, it's how do we manage them postoperatively? And again, we're looking at 3 things. What's their pressure if it's low? Get them off their medication. 2, check the anterior chamber. Do we have any IK, cornea, iris touch? And number 3, do we have any choroidal folds? They're just injecting a little bit of mitomycin C there. So what's the future hold? Well, there's a variety of different companies looking at different things right now. There's a excimer laser technology, the first one you see here, where they're actually creating these microchannels in the trabecular meshwork. So the laser punctures 10 microchannels in the trabecular meshwork. It can be combined with cataract surgery. This is currently undergoing clinical trials. The next one, the second one you see there, the use of a femtosecond laser and a gonio image. This is non-invasive. There's no incisions made. This is done with the femtosecond laser. It's creating these customized drainage channels in the trabecular meshwork. So that they use this gonio imaging device, a femtosecond laser to dock, and then the laser creates the channels to allow access to Schlemm's canal and the aqueous collector channels. The suprachoroidal space, or the uveoscleral space, still an area that we don't have a device. We used to have the CyPass stent that no longer exists. There is a device, a uveoscleral device, 5 millimeters long, that is being utilized and currently studied. You can see 2-year outcomes in a small subjects of patients, about 40% reduction in intraocular pressure. And then there's a stentless procedure, a MIGS procedure, where they actually remove a 90 micron cylinder of scleral tissue. It's an ab internal approach. This allows access from inside the eye to that subscleral or subconjunctival space. So they remove that scleral tissue to allow aqueous flow. So 4 different MIGS procedures, not FDA approved yet, but they're coming to market. So in conclusion, before I take some questions here, glaucoma definitely is both a medical and a surgical disease. We're managing these medically all the time with topical medications, and we're going to continue to do that. But we also have to keep surgery in our mind as well, and we have to talk to our patients about it. We want to understand it at a high level. The key to that is collaborating with our surgical colleagues, with our ophthalmologists that we work with in our community, to understand the different types of surgeries that they're doing and how we can partner with them in preoperatively preparing our patients and then postoperatively managing our patients afterwards, because the sheer number of glaucoma patients is only going to increase in the United States. These procedures, when we think about managing glaucoma patients, we want to think about trends in the treatment to balance effectiveness and safety. And what I mean by that is a patient that has mild glaucoma should not be getting a tube shunt anymore. A patient with mild glaucoma can get a stent procedure though, because it's an effective procedure and we showed with the data that's very safe as well. Mild patient can get SLT. We want to balance effectiveness with safety. And then I want us all to kind of have that interventional glaucoma mindset as we continue to manage our patients in the future. Still use medications. We're still going to utilize them, but have that interventional mindset of how do we reduce the burden for our patients. I want to thank everyone again for taking time away from family, friends, and other things you could be doing tonight. This is my email address as well. And thank you. I know this is my email address again. We have 2 slides with questions. I could throw this up there as well, and then I'll take some questions because we have about
Great.
5 minutes, I believe.
Yes, thank you so much for that really comprehensive review on MIGS and all the things that are in the pipeline. So we have, gosh, we have 1,100 people on right now, and so we have quite a few
Hey,
questions.
everyone. That's fun. Thanks for coming.
Yeah. So one of the questions when you were doing the burp video was, how long do you find that the IOP stays lower after burping the wound? This particular doctor said that he finds that the IOP lowering effect is short lasting.
It is. Yeah, it is short lasting. I completely agree. And studies have shown that as well. I think that it's important to make sure they stay on their glaucoma medication. And a lot of times with glaucoma patients, it's more the risk of what can happen to the nerve if we don't get it down fairly quickly. I've many times I had one today after a MIGS procedure, pressure was almost 50. Like that's a patient where, I'm gonna burp the wound because I don't feel comfortable sending them home on a medication and knowing that pressure, and we'll see them tomorrow. They're going to come back in and check in. And so agree, but I still think it's a valuable tool, especially in our glaucoma patients, just because they have a compromised optic nerve.
And you mentioned to burp the smaller wound. Is that usually always in a specific location?
It's surgeon dependent. Depends on the eye they're utilizing. So you won't want to search for that. It depends where the surgeon likes to sit. For my surgeon, I know exactly where it is because he operates the same way every single time. And so I know where it's going to be when that patient's there. But as you work with a specific surgeon, you'll know that they're very consistent on where they put their wounds. But yes, burp the small wound, not the large wound.
Another question is, how long do you expect these stents to last in terms of their IOP lowering effects?
It's a great question. We now there's some data out there, and we published this actually ourselves in our clinic retrospectively. So I always take that with a grain of salt, but I think it still matters from a real world standpoint. We have 7-year data out there right now that we published on a single stent. Now we don't have any with 2 stents, but a single stent, the first generation stent that was back in 2012. And a lot of those patients are still doing well. Now, what we've seen is that over that 7-year period, there's been a slight increase in medications. And so initially we had these patients down to about a half medication from like 1.7 medications. Over that 7-year period, we're creeping closer to the average being about 1. And so, yes, you're going to have to continue to manage these patients. But for me, the way that I think of it, I just think of a patient, I've just bought them 7 years of reduced medications. And yeah, I'm going to have to do something different, but I just bought them 7 years. And now we still have in our back pocket goniotomies or other different procedures available. And that's kind of the mindset that we want to have.
Great. And if you see a patient that has low blood pressure, what role does that play in your glaucoma management?
Yeah, I do pay attention to it mostly in normal tension or low tension glaucoma, just because we know there are some studies looking at perfusion pressure. There's a study looking at patients that when they sleep at night, they lie down. We know that our blood pressure drops at night. So if you already have a low blood pressure, so a hypotensive patient, and they lie down, then they get nocturnal hypotension, that can lead to progression. And so I do pay attention to blood pressure, especially in my low tension patients. And I want to know what their blood pressure is. And I want to make sure that if they're on blood pressure medication, that it's not making them hypotensive because that can lead to progression.
Great. Well, this will conclude our CE portion of the talk tonight. Would you mind telling us a little bit about what you'll talk about in the sponsor room? So some folks.
Yeah. Yeah, you bet. I hope you guys can join. I'm going to try to keep it to 30 minutes, I promise. But we're going to talk about drug delivery. Specifically, we're going to be talking about Durista. I alluded to drug delivery earlier. I'll take you through a case. I'll take you through kind of the ins and outs on it. If you ask me what I'm most excited about in glaucoma treatment, I'll tell you drug delivery is right up towards the top just because it minimizes the burden. It's that interventional glaucoma mindset. So I hope you got another 30 minutes. Understand if you don't, but I'd love it if you join me.
Great. Well, thank you so much, Dr. Schweitzer. It's always a pleasure to have you. I've always learned a ton, and I know our 1,000 participants did as well.
I appreciate it. Thank you. And I'm going to jump over there. So if I'm not quite there, everyone, I promise I'll be there shortly.
Great. Well, everybody stay tuned for that QR code, and then we'll walk you through how to get to the sponsor room to join Dr. Schweitzer.